My name is Dr. Chen from Pain Care Specialists of Oregon. Thank you for joining us. I look forward to talking today about options for management of chronic pain. We'll be going from very conservative, minimally invasive options to more advanced options for chronic pain throughout the body. Much of it will pertain to the spine, and we'll have an interactive session in a few slides that involves asking you questions and allowing you to also ask us questions as well as refer yourself. So let's begin. I hope all of you are having a pleasant evening. And we'll go to the next slide here. Okay. So we'll talk mainly about non-opioid options to manage your chronic pain today. You'll find at paincareoregon.com, as well as our YouTube videos from our Facebook Live event, some other opioid options, and we discuss how we treat chronic pain as well as the other doctors in our group. There's Dr. O, Dr. Vu, Dr. Cho. We're all board certified, double board certified interventional pain management specialists and anesthesiologists. There's also Dr. Gregory Gullo, who recently joined us, who works in West Lynn and Clackamas. We are now in Clackamas, West Lynn, Salem, McMinnville, Corvallis, so that we can help you find convenient locations to help you treat your chronic pain. This is our website, paincareoregon.com. We also have psychiatrists and neurosurgeon. There's a Dr. Allison Gullo, psychiatrist, and a neurosurgeon, Dr. Yaw Sarpong. We try to bring about the most comprehensive options for your chronic pain. So we'll go over that later in our slides about how we offer you quite a bit of comprehensive care at paincareoregon.com. We also work closely with PM&R doctors, neurologists, rheumatologists, spine surgeons from other areas, primary care doctors, chiropractors, naturopathic doctors, and physical therapists. So let's begin with an overview of how chronic pain affects Americans. It's extremely expensive from a financial standpoint, but we'll also go over how it affects others, around you, your spouses, your significant others, your friends. It's a huge cost, over 600 billion annually, and combined, it affects more people than heart disease, cancer, and diabetes. For workdays lost, over 500 million annually. That might actually be a low number, but we have a lot of reasons why we may feel pain. Number one, pain is your body's natural defense mechanism. We want to know when there's an insult, when there's a problem. It tells us to do something about it. But when it's more than 3 months and it's a chronic type of pain problem, it doesn't really have a large benefit to us. It becomes more debilitating and problematic for you and those around you. You have many types of pain, and we'll go over this later how it's subjective, but there's nerve pain, oftentimes described as sharp, stabbing, stinging. There's more of this kind of normal, regular pain where you might get from musculoskeletal injuries, bruises. It's kind of achy. Some people, when they get a gut ache, may even feel like it's like a visceral pain. It's a deep underlying pain. Then, of course, psychogenic pain. It's something that you're experiencing really through mental problems that you may be experiencing, stress-related type of pain problems, and that can increase the way you feel and feel pain from neuropathic conditions or regular pain. Mechanical back pain has to do with a physical problem on, let's say, a joint, a muscle, or disc. It can get better with sometimes positioning in a different way, but oftentimes you're just not able to find a comfortable movement or the posture. It can be described as off and on. For instance, if you have this mechanical back pain from arthritis in the joints, I have a little model here of where some people get arthritis in these little joints called facet joints. And often people lean back or to the side, and then that'll create more pain at your lower back where the arthritis is and cause you to not want to do that. And then you turn it off by trying to go back to a different position, perhaps leaning to the left to avoid pushing on that joint. Now, nerve pain, neuropathic pain, is different from mechanical back pain because it can feel much sharper. It can be going down a leg, an extremity, in a distribution of the way nerves are supposed to exit your foramina here. So you have multiple openings throughout your spinal canal where nerves run to different areas. There's nerves that go to your thumb, your fingers, your toes. Oftentimes it just isn't well relieved with positioning. Chronic neuropathic pain, meaning more than 3 months, is described in these manners. Numbness, tingling can be associated with it. It can be also sensed as hot or cold. And for patients to describe the severity, we have many ways of communicating. FACES scales, you have numerical pain scales, there's color charts like this. Now, how each person experiences pain is very different from another person. We all come from different cultures, we have different backgrounds, we have different life experiences. So how you feel pain is going to be very different from your neighbor, from your family members. And I'd like to now give you the opportunity to ask us some questions, but we're first going to ask you some questions about is your pain constant 24 hours a day, or is it intermittent? There's a questionnaire that's being sent to your screen, and you can click on some of the answers there. And how long has this pain been present? Where is your primary area of pain? So I'll just put down constant. Let's see. Let's say if I had greater than 10 years of pain, I would click there. And then my primary area of pain, oftentimes we see back pain. So I'll put down back. But here at Pain Care Specialists of Oregon, we see, we treat neck pain, upper back pain, leg pain, arm pain, shoulder pain, joint pain. So I'll put back. And I'll submit that. So that gets submitted, and we'll tally that. We'll take a look at that soon. And then you can even submit questions to us soon on your side. We'll answer a few. So let's go to the next one here. Okay. So we answered those questions, and what about what you're going to do when you're having a bad day? And how do I live with this pain? Well, there's a lot of reasons why you're probably having pain. Here's some of the more common ones: failed low back surgery syndrome, sciatica. People call that that shooting pain down the leg. There's also complex regional pain syndrome type of pain, phantom limb pain. People who've had amputations may sense that their limb is still there and it may be burning. Spinal joint pain. So that's what I was just getting at with the facet joints. There's discogenic pain. Your discs may get narrowed and you can feel pain from the nerves inside the disc. Joint pains, peripheral neuropathy. Let's go after this one. Now, people wonder, what are the best tests to diagnose pain? And we often talk about MRI, but there's reasons for and against ordering any tests. What are you going to do with the test after you get it? MRIs aren't always the best first step, but if you've had chronic pain and your doctor thinks that there may be a pinched nerve, it may be reasonable to order an MRI so that we can see the soft tissue. Versus, x-rays, you might have a plain film or an x-ray first if you start having pain and your doctor thinks it's musculoskeletal, maybe there's some instability to your bones, or you may have a CT. That's also a form of using radiation to look at your bony structures. But with an MRI, just remember that not all the things that you see that's unusual on MRI is necessarily causing your pain. In fact, 50% of us have something unusual on the MRI that isn't necessarily causing us anything. But for people with chronic pain that goes down the leg or goes down the arm, it can be often from a bulging disc, pinched nerves, the joints, which may cause the nerves to be crowded. There's something called stenosis. We'll look at some other slides about this soon. So here's an example of what an MRI could reveal. You're looking at a section where you've been sliced with this a sagittal section where you're sliced this way. You're looking out this way. The nerves are coming out towards the screen. There's a disc pushing on this nerve, and this may cause you to feel a shooting pain down towards the foot. So L4-5S1 would be probably the most common areas where we would sense, we would see something on the MRI that would likely cause you to feel a sciatica pain. Here's another way to look at the MRI where they're cutting you, making little cuts this way. This is the right side of your back, right side of your body. This is the left side. Here where you have stenosis, where parts of the spine are crowding the nerves as they go out. So you have facet joints here. This is a larger, these are arthritic joints here. And then as the nerves are trying to exit, the bones are getting in the way. The discs may be narrowed so that they're pinching more often than not, more often than you should be on these nerves that go down the arm or the leg, no matter what movement. Oftentimes people have problems walking even a few steps. Some people say that sitting may help, but it doesn't last very long. Then they start to fidget a little bit. They have problems sleeping. Surgery may be needed when this is severe, when there's a severe crowding or severe pinching on those nerves and causing weakness. When we look at how some mechanical spinal pain occurs, whiplash injuries or car accidents, motorcycle crashes, sports injuries may occur. We at Pain Care Specialists of Oregon often see car accidents, unfortunately, and this type of whiplash injury where you're stressing the disc, you're stressing these facet joints, may cause you to then pinch these little nerves inside the facet joints and cause headaches. It's hard to even just look up to the side, left and right, and then you become unable to stretch and exercise, perform your work or do your chores. Then your muscles get weakened and you have poor posture. You may then affect your other limbs. You may affect your lower back if you're not using your body correctly. Actually, let me get back to one thing here. The sacroiliac joint pain may occur as well from injuries, the motor vehicle accidents, because of when the rear end accidents, for instance, will cause these joints down here to be stressed and pinch other nerves there. Peripheral neuropathy pain, I would say, is becoming unfortunately more prevalent. Diabetes is a big cause of it. Unfortunately, our American diet isn't very helpful when it comes to controlling blood glucose. Obesity, unfortunately, is still an epidemic, just like the opioid epidemic. Diabetes will affect the way your nerves transmit information, and then you may feel sometimes start to feel tingling in your toes, and it becomes burning. You just can't find a position that alleviates it. Rest doesn't really take that away, because what's happening is basically the sugars are irritating and taking away the insulation of your nerves, and your nerves just are not working properly. You can develop complex regional pain syndrome from, it's a type of neuropathic pain, particularly in the extremities, but it can be from injuries or it can be just spontaneous. Unfortunately, if it's a very, very painful type of problem where even small movements will cause the nerves to be basically sending inappropriate signals. It's characterized by changes to the way you're sensing light touch. Your hair growth may be affected. You might have swelling. Your skin gets this strange patchy color changes. You may become very red, maybe really pale at some point. And There are even cases where we see frequently where the patient can't even touch their own skin. They're unable to even put a sock on, or put a glove, or have any clothing touch their skin. It's just unfortunate, very, very painful neuropathic pain. At Pain Care Specialist of Oregon, we like to start looking at the most conservative options, the options with the least risk. So we try to make sure that the patient has already attempted physical therapy, stretching, home exercises. We even encourage very low risk options such as massage, acupuncture, chiropractic care, non-invasive options. We are very interested in the cognitive behavioral therapies, biofeedback, very important when managing chronic pain. TENS units, over-the-counter medications, even transdermal medications, the topical creams, such as Voltaren gel, lidocaine creams. A lot of these things are now over-the-counter. When we still have problems, when the patient still has pain after these conservative options, we look at what's causing the pain. We try to figure out and diagnose and test what nerves perhaps are causing this back pain down the leg. We may inject specific nerve endings. We may actually inject joints under X-ray guidance. We use ultrasound to perform soft tissue injections, guide needles into joints that we think may actually be more of the problem than the spinal nerve. We have SI joint injections that we use X-rays to localize and inject the joint itself, and it asks you if you have at least significant pain relief and increased functioning. If all else fails, there's no surgical options, we may then look at advanced techniques, a little bit more invasive, but still very minimally invasive, such as spinal cord stimulation. And of course, opioids, narcotics. We try to avoid that for long-term chronic pain. We try to help the patient function without opioids as much as possible. We have a whole talk on our Facebook, Pain Care Oregon, Pain Care Specialist Facebook, as well as our YouTube. If you Google Pain Care Specialist YouTube, you'll see Dr. Young Cho talk about the psychological aspects of chronic pain management. She talks about cognitive behavioral therapy, biofeedback. We have Dr. Andrew O talk about advanced treatments such as spinal cord stimulator trials, implants, spinal injections. We have Dr. Kung Vu talking about some of these procedures. And of course, Dr. Yan Sarpong, neurosurgeon at Pain Care Specialist of Oregon, talking about neurosurgical options. Eventually, we'll have Dr. Greg Gullo as well. I think he'll be talking about some of the medications and particularly risks of opioids. This is a very important topic. I think what we try to do is help a patient avoid increasing use of opioids. Unfortunately, opioids, narcotics such as oxycodone, Vicodin, methadone, fentanyl, they cause a patient to eventually become tolerant. And it may be a matter of days after taking this that you just don't sense a good relief from using any opioid. Your body just gets used to it, unfortunately. And the side effects can be just unbearable. Nausea, constipation, and if you don't take it regularly, you may get withdrawal. Then, of course, we worry about the breathing problems that may be associated when you take too much at once. You may not have the right, clear thinking when you're at work or driving. We try to utilize as much as possible the non-narcotic, the non-opioid medications. You have over-the-counter ones like Tylenol, you have NSAIDs, ibuprofen, meloxicam, antidepressants are very important. These medications can increase important chemicals that your body already makes, but you just need more of it, such as serotonin, norepinephrine. You have very powerful, safe medications like Lyrica, Neurontin, relatively safer, of course, than opioids. And we'll go further to then our injections. We looked at these options, and these are all detailed further in our video tab at paincareoregon.com. On the website, you can look at epidural steroid injections, which many of you have heard of, where we coat nerves and determine which nerve is likely causing that pain at the spine. Medial branch blocks, those are nerves inside these facet joints. We are able to test those medial branches and ask you to start to move about on one side or the other, or look up and down and tell us if you get significant pain relief. If that occurs, then we do something called radio frequency ablation. That involves lesioning, basically disrupting the nerves of the small tip probe. And the nerves may take months to years to grow back, so that when you're turning your head, looking up and down, leaning left and right, you may not feel so much of that pain that's from the medial branch nerve being pinched inside that facet joint. Sacroiliac joint injections are important when people continue to have pain when they are sitting on that joint. It's basically your joint of your buttock right here. You sit there and there's nerves inside that get pinched. Some people have injuries, or some people just simply have arthritis develop over time. They degenerate. Some people have fusions, lower back surgery, where these areas are not able to move. Normally, when you're moving, you have to distribute the forces throughout the lower back. But if you're fused, then the sacroiliac joint here at the bottom has to take up more of the work. They have to work harder to allow you to perform some of the movements that you used to have before the fusion. Here's an example of a transforaminal epidural, where we go from a side and we select specific nerves, special areas that we think are causing the problem because we've reviewed your symptoms. We go through a detailed history and exam and an MRI sometimes. Then we ask you a few days later if this has helped. A surgeon may ask for this before they perform surgery, just to minimize the amount of decompression and surgery that you may need. We always want to try to target the most likely cause of the pain. So do the surgeons, and they want to avoid having surgery at multiple levels if possible. Here's a facet joint injection, and this is the radio frequency ablation, where the small tip probe is placed to lesion that nerve before it gets inside that facet joint. Here's a sacroiliac joint injection. This is fluoroscopy. It's a type of x-ray that we use, very low dose, but we're able to see live how this contrast spreads. This is omnipeg going up into the facet joint. And unfortunately, if all else fails, as we had mentioned with that first tier, second tier, third tier, sometimes spine surgery is needed. Sometimes spine surgery is actually needed before everything else because you've had severe pain. If severe pain, weakness, and debilitation occurs, especially weakness, the spine surgeons will be looped in first. The relief of that pressure on a nerve is critical earlier than later, because if you don't relieve that problem, the weakness, it may become permanent, unfortunately. And again, Dr. Yas Sarpong at Pain Care Specialist of Oregon on Facebook Live, and if you YouTube search it, he'll have a very nice YouTube video about neurosurgical options for spinal issues. Here are some of the reasons that I had mentioned why you may actually need surgery. We can go over that a little bit later. But what else is there if you've failed all the first line options? Well, and the second line options, and your surgeon, for instance, if Dr. Yas Sarpong says, no, there is nothing that would really help at the lumbar spine, or there isn't something at the cervical spine or lumbar spine causing that shooting pain down the arm. We had just reviewed CRPS, we had reviewed other neuropathic conditions, such as diabetic peripheral neuropathy at the hands and the fingers, or the toes and the feet, and there really is not a good spine surgery to cure or to alleviate that type of neuropathic diabetic peripheral neuropathy. What else is there? Well, luckily, we have something called neurostimulators. We have something called spinal cord stimulators. We even have peripheral nerve stimulators that can stop these neuropathic conditions that really are not amenable to surgical decompression, spine surgery, or fusions. If a person has tried many non-opioid medications, neuropathic medications like Lyrica, Neurontin, and some of the other medications that we've mentioned that are antidepressant in nature, but mainly for pain, we would want to use Cymbalta, Effexor. They've had physical therapy. Then we look at spinal cord stimulators. Spinal cord stimulators are very well regarded. There's quite a bit of study and research showing that the spinal cord stimulator has a great role in neuropathic pain conditions. It's been used for even chronic angina, patients who have heart pain, vascular problems at the lower extremities, CRPS, post-herpetic neuralgia pain. You know, when you get chickenpox, that virus lives in your dorsal root ganglion, part of your nerves in your spine, and that may reactivate and cause you to have that nasty rash, really painful burning pain. It can oftentimes be at the upper back, and a neurostimulator can turn that off. You have diabetic peripheral neuropathy pain. You have scar tissue sometimes that forms around the nerve roots of the spine after surgery. That's called epidural fibrosis and scarring, and even more surgery is not going to necessarily take care of that pain. And neither will narcotics, steroid injections, and there's only so much the PT can be utilized to alleviate some of that pain. But what we look at with spinal cord stimulators are a very minimally invasive way to put an electrode over a nerve ending. Oftentimes it's done with just some light sedation, IV medications that you may have already had for instance, during other procedures that allow you to still be aware of some things going on, but you'll be very sleepy and relaxed. We put quite a bit of numbing medicine at the skin, and we can place electrodes throughout this spinal canal to turn off specific nerves that go to different locations of your body. So for headaches and neck pain, we'll place it closer here. For lower back pain, leg pain, we'll place it here. And there's even ways to stimulate an exiting nerve that may be the reason why you're feeling some pain at the fifth toe or the fourth toe. Sometimes after knee surgery, you might have pain, and we can turn off that nerve about here that goes down towards your knee. If that is your surgeon, for instance, your orthopedic surgeon has already done 2 or 3 knee replacements, and they don't recommend any more. There's really no other surgical option at your extremity, at your knee. So what this electrode does, these small electrodes placed within this spinal canal stop the signaling of pain going through the nerves and being processed here. So it's basically a roadblock to your to these signals of pain coming from different areas of your body, and we can target electrodes into different areas of the spine. And this is a external. During the trial, we typically run a 5 to 7 day trial for a spinal cord stimulator to let you tell us if this is something that's helpful before we implant anything permanently in your body. And again, this is all placed through X-ray guidance, and while you're sedated. We don't cut the skin. Once the small electrodes are placed at your spine, the power is adhered, it's taped to the back, and there's a wireless transmitter that allows us to program each electrode, and you tell us over 7 days, 5 to 7 days, whether or not it has helped you sleep better, move with less pain, maybe even take less opioids. We've had people not even have to take oxycodone and fentanyl during the trials. So that's a big plus. Then after about 7 days, you come back and tell us at the clinic, we just remove the electrodes, and you tell us whether or not you need more time to think about a permanent implant, or if you wish to proceed. All the equipment that you just saw on that slide there, the battery here, as well as the electrodes right here, can be implanted under the skin. And I recommend that you actually go to the paincareoregon.com website to look at patient testimonials, which will have even more detailed videos and electrodes. We can look at it. testimonials from patients about what they did during the trial, what they did after the implant, why did they decide to wait for an implant, or how did another patient describes what they did after an implant that they never thought they could do again. And I think there's about 4 to 5 good testimonials. And then there's a few other videos on the video tab on the left-hand side that you can scroll through. Um, so we want to show you just a few more options of what, spinal cord stimulators, what types of pain problems spinal cord stimulators can take care of. But there's another options such as a paddle implant. This paddle is different from the spinal cord stimulator trial because this is something that can be inserted and taken out through a small needle. And at the clinic level, that is, after a trial, we can just slip this out from the spinal canal and the skin. But this is a permanent implant that's placed by a neurosurgeon or an orthopedic spine surgeon over the nerves that we determine to be the ones causing most of the pain during a spinal cord stimulator trial. This will use a lot less energy. This will give us more options to program over several groups of nerves in case this moves a little bit in the future. So we'd like you to take a look further into the website about these spinal cord stimulators and why they're useful. We have a lot of research available for you too. But I'd like to end this talk with basically our goal is to always provide you the least invasive, highest benefit treatment, whether it's a combination, and it's usually a combination of good non-opioid medications, minimally invasive therapies such as physical therapies, coordination with pain psychologists. Now we have Dr. Allison Gullo at the Westland and Clackamas location for psychiatry. And then Dr. Greg Gullo, also an anesthesiologist in Westland and Clackamas, helping neurosurgical review with Dr. Yao Sarpong and the other interventional specialists and anesthesiologists, Dr. Youngmin Cho, Dr. Kung Vu, Dr. Andrew, and I can help find certain areas that nerves that may be causing the pain. We take care of a lot of your concerns with how to communicate with your referral sources. We now have ability to use not just phone calls, but texting and secure HIPAA compliant emails, patient portals. We're able to do a lot of surveys through programs such as this WebEx program, where you're able to submit your data through secure channels so that even before you come see us, we're able to do some advanced treatment planning. And I'd like to just show you some of the videos that you'll see if you were to look at the Pain Care Oregon Facebook. There's a lot of good options for you to kind of discover on your own at home, in the comfort of your home, what I had talked about briefly in some of the slides. We think it's very important this year, in particular, more than any year, that you, the patient, your family, your friends, have these very high quality educational videos so that you can decide whether or not you should proceed with this option, this therapy. Do I want to see this doctor? What's my best next step?